I guess I will start, and I'm just going to quickly introduce some colleagues here, Kayla Perry and Tannyce Cook at the Diabetes Integration Project. That's at the First Nations Health and Social Secretariat of Manitoba. Again, I'm not even sure what numbered episode this is for us, but our ongoing learning series where we try to get our friends and colleagues to join us and talk about the work that they do and present to the people that want to learn about it. So and connect. So with that, I'll let Kayla and Tannyce introduce themselves and take it away. Thanks.
Awesome. Thanks so much for having us. So we will be presenting on the Diabetes Integration Project that we work with and what we do now and what our future plans are. Yeah. All right. So I always like to start with my spirit name. So Gnu Gabin Nundagazidikwe in Indigenous cause. My spirit name is Eagle Calling Woman, and I am a member of Rolling River First Nation, which is under Treaty 4. And I'm speaking from Treaty 1 territory today. Some other fun facts. I have 4 children. I have 2 little ones, and that's Lane and Phoebe. And those are pictures of their naming ceremonies. A picture that I love of my grandparents dancing with me at my grad powwow way back when, and I look super young there. And then some more recent photos. My stepchildren are now 16 and 18. So this was a couple years ago, this photo, about a year ago. And we had the opportunity to go to Mexico for our Christmas break this year. So that's some photos there of my husband. Yeah, and so I'm a dietitian and diabetes educator working with the Diabetes Integration Project. I've been with the project since 2016, so going on 8 years around there, some mat leaves in between. And I'll let Tannyce introduce herself next.
Tanse, everybody. My name is Tannyce Cook. I'm from the Mississipaugastic Cree Nation in northern Manitoba. I've lived in Winnipeg for most of my life now, I guess. I'm a registered nurse. I've been a nurse for about 15 years. I have 2 boys, and most of my life is dedicated to being a hockey mom. It's what I love to do the most in my life. So I got a couple pictures of my boys playing hockey there. And now they're growing up, and so now I have a dog. So that's my little baby Kenobi right in the middle there. So
awesome. So we wanted to find out some more information about you folks, see who we're chatting with today. So I have a Mentimeter. So you just have to go to menti.com and enter this code, and then these questions will show up. And I'm going to share my Mentimeter. So the first one is, where are you watching from today? And I see that some of you put that in the chat, but I thought this would be a nice visual of where everyone is coming from. And I've never done this sort of map pinning thing, so hopefully it works out.
Hey, Kayla, could you maybe put the Mentee info in the chat and people can just access it there?
Sure, yeah.
Thanks.
Chat.
I could have done that. I'm sorry.
Okay. Oh. 4 on there. Can we get some more? I think there's 25 of us here.
Oh,
I
yeah.
know sometimes it takes a little while to get
Mhm.
onto the site and everything.
Gonna say I know there's some Alberta and interior BC there.
I was wondering if that's how it would work, where if somebody pressed the same area, if it would kind of have numbers. So
Hmm.
it shows up as a 2 there. Do we have anyone in BC right now?
Yeah, I know there's somebody from BC. I keep seeing Catherine's name pop up in BC, but then it disappears again.
Oh, maybe
There she goes.
there we go.
Yeah.
That's so cool. We have 10. Give like 1 more minute. See if people can put it in there. I'd also just like to let everyone know that my son is home today because he is sick. So if he comes over and is loud, yeah, he's turning 5 right away. So it's a fun age. All right. Well, we'll move on to the next question. So just wondering what your area of work is, maybe what your profession is, or what sector you work in. I think you can put in multiple responses to this one. This will show up as a word cloud. So if, for example, there are multiple dietitians and multiple people put in dietitian like that, then it'll be a bigger word. Awesome. Wellness journey support. I love that. Got some researchers, policy analysts, nursing. Awesome. So you can see that there is probably a few dietitians because that word is bigger than the rest. Nine people who have responded. Okay, that's awesome. People in lots of different areas. We'll move on to the last question. And it's just how often do you work with First Nations people? So is the majority of your work with First Nations folks, some of your work, or none of your work? So the 10 people, 11 people that have been answering have answered. So most people mostly work with First Nations people. That's great. All right, thanks so much for participating in that. As this is your slide.
Oh, so sorry. So just a little bit, the history of the Diabetes Integration Project. So way back in 1999, there's a Diabetes Leadership Committee that's, it's comprised of all the tribal council areas and independent communities in Manitoba. They have a representative that sit at a table. And they were mandated, they were told by the chiefs in Manitoba that they had to figure out what was going on with diabetes because there was so many First Nations people being diagnosed. So they came up with the Manitoba First Nations Diabetes Strategy, call to action to address the epidemic in Manitoba First Nations at that time. So they came up with the 5 priority areas, which were prevention and promotion, care and treatment, gestational diabetes, research, surveillance and education or evaluation, as well as policy and infrastructure. And from that care and treatment section, the Diabetes Integration Project was developed in August of 2006. So the overall goal of DIP is to enhance diabetes care and support for First Nations adults who have been diagnosed with type 2 diabetes to prevent or delay the onset of complications. So this is just our DIP staff. We have 6 nurses employed at the time, 2 dietitians, and myself, the director of the program. And then we also have a research side of DIP. So right now we have the Kidney Check Project as well as the IK Health Project. And then our admin support is Renee. So those 6 nurses and the 2 dietitians, they currently provide mobile diabetes care and treatment to 18 First Nations communities in Manitoba. You can see the little dots there. So majority of the communities that we service are in the southwest. And then there are some in the north that are isolated and remote communities as well. So we have 3 teams. The south team services Chimawawin and Easterville. That's kind of weird that Easterville's in the south team, but it's because it's a drivable community and that we just to make trying to even out the amount of communities that the team service. So they do Easterville, Sandy Bay, Hollow Water, Long Plain, and Peguis. And the north team services God's Lake Narrows, God's River, Nelson House, Oxford House, and Split Lake. And then the Dauphin team does the most communities. They're in Pine Creek, Ebb and Flow, Gambler, Crane River, Keestikuvinen, Rolling River, Skowhenan, and Valley River. So majority, like because they do have more communities, but they're smaller. So a lot of their communities are only 1 or 2 day clinics in the month instead of 3. So that's the communities that we service. And those are just some pictures there. Sometimes we have to fly in, sometimes we drive, but we always have to take all of those kits. So there's at least 4 or 5 large kits that you're traveling with. A lot of times we have to take our own food in for the week too. If you're in the north and you're not able to just, hit up a grocery store or whatever. So a lot of times you have to carry your own food as well for that week. So it is a lot of stuff you have to take with you while you're traveling. Did you want to switch the slide, please?
Okay. So just our approach to our work. We take a holistic approach. This is my son Lane. We take a holistic approach. We often, make sure that we're talking about spiritual health, emotional health, physical health, and mental health as well. And we also are using strength-based an approach. So we don't just focus on weaknesses in communities or with our clients. We make sure that we talk about things that they're doing well, things that are positive in our communities. A client-centered care approach. We focus on the client and their agenda rather than our agenda. So making sure that we are helping them with what they want to talk about or what they need help with at that time. We're using a harm reduction approach. So if folks are, for example, drinking alcohol, then we talk about ways that they can make sure that they are safe while they're drinking alcohol with diabetes. And we use a non-judgmental approach to our work. So there are lots of different reasons, for example, why people might not show up to an appointment. We make sure that we aren't judging people for, if they're late or if they can't make it last minute. And there was one thing I just wanted to share, just in my notes here. We don't use words such as non-compliant, for example. If somebody's not taking their medication, we know there's lots of different reasons for that, and we don't call them non-compliant clients. One thing that I wanted to talk about was shifting our thinking from something like Indigenous people are at greater risk for developing chronic diseases, which is often what you hear. And we want to shift the thinking to systemic racism creates gaps in care that puts Indigenous people at greater risk for developing those chronic diseases. So for example, if you take a moment and just think about the statement, being First Nation is a risk factor for diabetes. So that's something that we hear. It's something even on like Canada or Diabetes Canada website, under risk factors, there's ethnicity. So being First Nation is a risk factor for diabetes. So just think about how that makes you feel when you hear that statement. So it's sort of putting the blame on the First Nation person. And so instead, I want you to think about racism as the risk factor, not First Nation. This is something that I use in my work with clients or just even in presentations with people. And I just always try to focus on balance. And we know that being in balance keeps us well. And so with assessment, sometimes I will use this medicine wheel and I'll just draw it on a piece of paper and ask people what activities or practices they're doing in each of these areas of health to maintain those aspects of health. Which aspects do you feel like you're not spending enough time in? And then that way we can focus on that area to find out things that they can do to be more in balance. This is something that I learned at a IDHC conference from a traditional knowledge coordinator. And I think it's just something that's really stuck with me and that I really like using with people and people really resonate with. And this one's yours, Tannyce.
So some of the clinical services that the DIP teams provide is point of care testing, diabetes management education. So we try and look at what their results were from those point of care testing and what we can do to improve those numbers if they need to be improved. They do a medication review, basic foot assessment, nutrition education and counseling, and then specialist referrals as required. So we can refer to endocrinology, foot care, any referrals that are needed. The DIP has a referral pathway. So the point of care testing is really the big one that we do. So, sorry, there we go. So we get on the spot results. We take, the DIP nurses take 2 DCA machines, those are the white ones, and then the blue one in the middle is a Piccolo machine, they're called. So one of the DCAs is used to check your A1C, which is your average blood sugar over 3 months. The other DCA is checking urine for protein, and then the Piccolo is used to test your GFR, which is your glomerular filtration rate, which is a number that tells us how well your kidneys are functioning. And we can get all of these results in less than 10 minutes, and we can go over those numbers with the client, kind of letting them know what it means, how we can improve those, etc. So the clinical services, there's usually 2 diabetes educators per team. We try and keep 2 nurses or a nurse and a dietitian. And then the dietitian also makes their own visits independently out into communities as well. We're trying to get to each community 3 or 4 times per year. So quarterly visits to every community. Clinics are 1 to 3 days long, depending on the community size, like I mentioned earlier. We work very closely with the Aboriginal Diabetes Initiative workers in the community. We rely on them to book appointments and to get the people into our clinics. So they're a huge part of our team as well.
All right, so I just wanted to touch on some of the previous projects we've done, especially during COVID when we weren't able to go out to communities. We did try to support people individually over the phone or virtually. We even provided laptops to each of our communities so that we could do Microsoft Teams visits with folks. But some other things that we did were really trying to focus on our Facebook page and share information on there. Please check us out on Facebook. I think we need to still work a little bit more on our Facebook page, but we try to share things on there when we can. And so one example is, this is one of our nurses in the Dauphin area, and we had kind of like, what's your favorite food type of thing, and interesting slides. And we did a really big meal kit project that I think went over really well. Another dietitian and myself did that at our office. And so here's a picture, or pictures from God's Lake Narrows. Is one of our flying communities that we work with, and Bobby here is the ADI worker, and he, ensured that that people got these meal kits. So it included a recipe and the non-perishable ingredients for the meal kit for people to make, and they could follow a video that we made for each of them. We did 4 that we have on our Facebook pages, but I wanted to show you guys one of them because I think it was a really good project. I had it open.
Let's make a hearty lentil soup.
You'll
need the recipe, a spice bag, lentils, barley, and beef bouillon, and a can of tomatoes, 8 cups of water, an onion, 2 stalks of celery, and 2 carrots. Start by placing the 8 cups of water into a pot. Add the lentils, barley, beef bouillon, and salt, and give that a stir. Bring it to a boil, and then reduce the heat to low and cook that for 20 minutes. While that's cooking, prepare the vegetables. This includes peeling and chopping the carrots, celery, and onions. Fact about lentils. Lentils are a great source of protein, fiber, and iron. There are many types of lentils. The ones that we're using in this recipe, red lentils, cook quicker compared to other types of lentils. When the barley and the lentils are soft, you can add the canned tomatoes and the vegetables as well as the spice mix, which includes garlic powder, cayenne pepper, pepper, and oregano. This is a vegetarian recipe loaded with protein and fiber from the lentils and the barley, but if you would like, you can add a meat of your choice. The soup is ready when the vegetables are tender and the soup has thickened. Now it's time to enjoy. The soup is great on its own, but if you would like, you could pair it with something like a sandwich or bannock.
We hope you enjoyed this video brought to you by the Diabetes Integration Project.
Let's make a hearty lunch.
What was that?
Hearing something else now. Okay. All right. Some of the things that I've worked
Kayla?
on.
We can still see the hearty lentil soup.
Really? Okay. Oh, close it. Not showing on my screen. Yes. Yeah. Are you seeing the slides now?
No,
Oh,
Just really wants to share that with you guys some more.
it's making me hungry.
Yeah. I don't even have it open. I closed it on my screen.
Is the browser still open? Maybe if you shut
Yeah.
down the browser.
Oh, I closed it.
Wow.
you
Yeah.
can try stop sharing and then probably start resharing the slides again. from
Okay. How about now?
Yes.
All good.
It's good now. Okay. Now I can't see myself. Hmm. Well, I can't see myself anymore, but that's okay, as long as you guys can see the presentation. So something else that I worked on, actually, Jeff, when he was with the National Indigenous Diabetes Association, asked me to help with a coloring book. And so this is available on their website, the NIDA website. I just provided the nutrition portion of traditional foods, and it is really neat. So I encourage you guys all to check that out as well. This picture here is of Destiny, one of our DOFA nurses, when she was at a COVID clinic, and something that she shared, that it was -50 weather and they weren't allowed to have exposed skin, but they were doing a COVID clinic in Garden Hill First Nation. So, just to go on with the meal kits and why we did that. Part of it was because the food prices are a challenge in a lot of our communities. This is one of the flying communities, some photos that one of our dietitians took. And you can see like a little container of strawberries is 9 something. I highlighted this one here, like Activia 12 containers was $13.40, I think it is. And here's an example of what you can get right now at Superstore here in Winnipeg. The same kind of yogurt for $6. So that was a reason that we wanted to provide people with foods and give them some different recipes to try that are, you know, less expensive but can go a longer way. Some other things that that we do are sharing our story, what we do with DIP, sharing information and education to people in larger ways. So conference presentations. This is the National Indigenous Diabetes Association conference that was in Halifax that I'm presenting at. This is an example of what our booth looks like, some of our staff there, and a presentation in one of our communities at a health fair that I did on just how much sugar is in different drinks. Tannyce?
Okay, so some of the other projects that DIP is involved in is Kidney Check, the IK Health Project, as well as the Diabetes Business Case. So is there slides on each of these?
Right.
Yeah, so the Kidney Check Project, I know that I can hear Catherine Turner's voice, so she knows a little bit about this. So what we do with the Kidney Check Project is kidney screening. We work with Dr. Paul Commenda in Manitoba here, and he's the tall guy in the green shirt there. And we have been doing kidney screening in some First Nations communities. So using almost the same model as DIP, just slightly different. We're looking at kidney health in First Nations communities. So we're trying to look for screening kids aged 10 and up. We can calculate their risk of developing kidney disease in the next 5 years and then provide education and referrals based on those results. So we have another team of nurses that do the kidney screening as well. So that brings kidney, diabetes, and blood pressure testing to rural and remote Indigenous communities. On the spot results, again, using the same machines. We don't use the big blue Piccolo. We use a smaller iStat Alinity to check a client's serum creatinine. So we look at their blood, the protein in their blood. We look at their urine for any proteins, and then we also do the A1C as well. And then taking that information, looking at their blood pressure, their height and weight, and ethnicity again, we're able to calculate their risk of developing kidney disease. And then based on those risks, if they are medium or high risk, they're referred to immediately to nephrology, to Dr. Paul Commenda at the Seven Oaks Hospital for follow-up and care as needed. So the Kidney Check has done screening in 5 communities, but then there's also the virtual check communities. That's another project that we have been participating in as well. So we're looking at getting kidney screening as more of a public health. So like breast cancer screening or colon screening, we want kidney screening to be something that everybody gets done as well at a certain age in Manitoba. So we're doing a mail out. So some people, anybody who's eligible for kidney screening in those 4 communities is going to receive a letter in the mail telling them that they're eligible, and then to go and get kidney screening done. So based on those results from that, we'll be looking at possibly making kidney screening more of a public health thing in the future. So, and then IK Health that's a research project, so a qualitative and quantitative research project with Dr. Jose Lavoie and James Zacharias at the University of Manitoba. We have Reed Whitlock, who's like a master at analyzing data at the Chronic Disease Innovation Center. He helps us out with that too. So just looking at medications, different, looking at the timelines of people who have been on dialysis, who were late starters. A large portion of people who find out very late that their kidneys are sick and they need dialysis within a few months of finding out that their kidneys are sick, a large portion of them are First Nations people. So the IK Health Project was looking at the reasons why, looking at their, based on their health, their data, when they were being seen, what testing was being done, and why they were finding out so late. But then we also did a lot of interviews with people who are actually living that experience, who we're either a caregiver or a person on dialysis in that situation. So this is coming to a close soon. We're just wrapping up all of our data and writing out our findings, but we are going to be looking at expanding this project, applying for some more funding to look at maybe changing policies around transplantation and possibly looking at putting people who live in the north, kind of giving them better access to transplantation and kidney care. So that's what the second phase of IK Health will be. Also, a few years ago, the chiefs also mandated FNISM to look at expanding care, advocating and looking at applying for funding for the diabetes business case to have, like, instead of having people like our team who goes out into the communities and does this point of care testing, we are advocating to have that money in the community, that they can have their own people in the community every day doing point of care testing and screening their community members. So we're working in partnership with the MFNDLC to prepare that business case to present to federal and provincial governments to get to invest that money where it's needed and to get that money into First Nations communities so that they can care for their people in a proper and good way. So we wanted to shift to working with youth. I think for me, it was really working in the Kidney Check project and working with the kids, looking at 10+ and realizing that type 2 diabetes is 25 times higher in First Nations children. If you're a Canadian, your chance of kidney disease is 1 in 10, but if you're a First Nations person, it's 1 in 3. So all these things kind of got me thinking, like, we got to start doing more at DIP, like, because right now we're only working with adults who are already diagnosed. So I want to get out there more and finding kids, finding our young people who are already their numbers are already starting to creep up and they're starting to get sick, and then working with them to bring those numbers down, because research shows that if you are caught diabetes early enough, you're seeing those numbers rising early enough, making those lifestyle changes is going to go a much longer way in bringing those numbers down.
Right. Okay, and so along that line, we are starting to plan for a diabetes youth camp. We have a student with us right now, Maya. I think she's listening, and she was on a picture on one of those slides earlier, a dietitian student. So she's helping us to develop this plan. And so we want to work with First Nations youth aged 18 to 25 years old that are at risk for diabetes. So we know that this group of people, if they do have diabetes already, type 2 diabetes, they're aging out of the children diabetes program and are less likely to be seeing their doctors regularly. And even if they don't have diabetes, we know that this age group doesn't see their physician regularly as much, and so they are likely not being screened when they should be for diabetes. And so we want to work with this group to provide education and awareness on living well with diabetes. We're going to create educational resources that are more geared to First Nation youth, and use a strength-based harm reduction approach with our First Nation lens. And with this project, we want to develop youth lifestyle ambassadors or diabetes mentors that can empower even younger youth in their communities to prevent diabetes and its complications. So what we did was met with a youth council with the Diabetes Education Resources for Children and Adolescents group. They have a youth council of folks, youth that have type 2 diabetes. And so we asked them some questions. These are just some examples of, we also did a Mentimeter and made some word clouds with things that they were thinking when they were diagnosed with type 2 diabetes, what they were feeling at that time, what they were doing in their life at that time, and what they were hearing from people like family, doctors, or from themselves or peers. So we collected some data from this meeting and asked them what they think would be really important for including in this youth camp. So some themes that came out of that meeting, that engagement session, many participants experienced fear, confusion, and a lack of mental health supports at diagnosis. So making the transition to adult care was especially difficult. Managing diabetes was challenging due to inadequate education, systemic racism, financial barriers, and burden of constant self-advocacy. Cultural factors, including limited access to relevant nutrition education and exclusion from traditional meals, contributed to feelings of isolation. And despite all these struggles, participants did find strengths in advocacy, community support, and skill building, and emphasizing the need for positive role models and systemic change. So we came up with this very preliminary schedule for what a 3 to 5 day camp could be like in a community. We have to still bring this back to the youth council and get more of their feedback. But generally, we have kind of like a first day where a nurse and a dietitian would go out to the community. So there have to be variation in travel time, depending on the community. We would want to have a meal together, have a feast with the participants and their family members, the community support workers that will be involved, do kind of the registration, introduction to camp stuff. And the first day would be a lot of basic understanding of diabetes, going over pathophysiology in ways that are more fun, or ways that are easier to understand. We're going to include some movement, of course, in our camp, and nutrition education. We want to actually do things with the youth, like going for walks and actually seeing or talking about that effect on blood sugars. Sorry. We want to make sure that we're including spiritual health as well as mental health and emotional health. So having a sharing circle on traditional foods. We have sharing circles kind of throughout. Cooking workshop, talking about basic cooking skills. The second day, we would have more of activities where we would go out to a grocery store and actually shop for foods and ingredients for the youth to make a feast on the last day. Some more learning about diabetes through active games, talking about stress and its effect on blood glucose, relationship with food and coping skills. We want to include elders from the community to talk about traditional medicines and diabetes and overall wellness. And because we want to help to create youth mentors, we would try to do something in the evening one of these days to have the youth that we're working with to facilitate a game with younger ages. And something that the youth council said was really, really nice, or would be nice, is to have a bonfire. So we're trying to include that there in some instances. Another thing that they really encouraged was having a speaker come with lived experience with type 2 diabetes, particularly a youth, but just anybody with lived experience, and to share strength stories as well. And then lastly, we would have a cooking workshop with with them and invite all of those support people back. And then a little bit of evaluation and assessment. So we have them in here listed or highlighted as, you know, more focused on the physical health, emotional health, mental health, and spiritual health. You can see the colors there. And then green kind of encompasses all 4 of the areas. So we just want to make sure that we're including things in all of those areas of health. So we thought this would be a good way to do it. And lastly, just wanted to touch briefly on some anti-Indigenous racism training that we have at FINISM. I'm one of the facilitators for the training, but Cheryl Drever is our anti-racism project lead, and I believe we also have another anti-racism training coordinator starting soon. It's been very, very busy, but also very successful. To date, since 2021, there's been 76 participants, and 73% of the participants haven't had any anti-racism training before. So we can see that it's needed, and it is really making an impact. So some groups that we've had do the training are dietitian students in Manitoba. In 2021 and 2022, it was dietetic interns, and now the program has changed a little bit, and now it's they're dietitian students doing a master's program, but also an internship. So we've done it with 3 of those dietitian student groups, and as well as some gold surgeons and folks from CRIM, which is the Children's Health and Research Institute in Manitoba. And this is just an example of what our training entails. It's an 8-week training, and a lot of it is done through virtual sessions, but we typically do the orientation and closing session together and share some food. Yeah, and so this is a picture that Cheryl put together. She's very artistic, and just showing what the Dream CRIM cohort did and what kind of came out of that group doing the training. And there's her contact information if you want some more information, or if that's something that you would like to partake in. And yeah, so that's our presentation. Thank you so much for listening. We are happy to answer questions. This is just a nice photo of our team, most of our team. We're missing a couple of people from our holiday dinner, and just to show that we have an excellent team, and we can be fun sometimes.
Awesome. Thank you, Kayla and Tannyce. Yeah, we just open the floor for questions or comments. You can do the raised hand thing, or write something in the chat, or just unmute yourself and ask away. Thank you both for presenting all. That's awesome. I had shared, when you were talking about prices in the north, I shared that picture in the chat that Salma Makwa had shared on LinkedIn. He's a provincial MP in Ontario for Northwestern Ontario. He's in one of the communities there. Yeah, for berries and whipped cream.
That's
and
wild. And then it makes me wonder, like, probably nobody ever bought that.
Goes in the trash. Yeah.
Yeah.
Hopefully feed some birds.
Bears at the dump later, maybe.
Yeah.
It's just one of the many issues too, right? But I just wanted to kind of highlight that one, because we were trying to help a little bit with it, but even the prices have gone up so much more since then.
Questions, comments, anybody? I guess a general sort of I don't know, monitoring or whatever question. I never used to get my A1Cs checked. And then when I got a new doctor a few years ago, just anytime I got blood tests done, he threw it on there, which like since then, I always encourage people to get A1Cs done on their blood tests.
Yeah, that's one of the resources that we are working on. So our clients come to us, we give them their A1C, like, oh yeah, okay, your numbers look good, or you know, your number is a little high here, but I want to have a resource like, this is your A1C, this is what your result was today, this is what it means, this is what an A1C is, because there's so many people who don't know that. Like for us as healthcare professionals, it's like, oh, well, yeah, you know, we know what that is, but there's a lot of people out there who don't. So just giving them that information, I think, will go a long way too. And be like that, having that in the back of their mind, like what their A1C is and what that means, I think will help as well.
And it's a pretty easy indicator to come by too, right? Like if you're seeing a doctor on any sort of regular basis or whatever kind of basis, then at least they can run that test for you.
Is another huge problem. A lot of people don't see doctors regularly, so.
Yeah. Questions, comments? I see that Momo says thanks. What is the Facebook name? I would love to share recipes with my clients.
I cannot. Sorry.
Throw it in the chat.
Do you have any animals? I'll type it in the chat.
Okay. And then Natalie Rediger says great work. A lot of projects going on. Interesting students educating such an important piece. And then Rose said, absolutely wonderful presentation. I wish our province was so active in addressing diabetes. Rose is from BC, and Rose is part of a group that puts on the BC Aboriginal Diabetes Conference every year in usually Penticton, I think, Rose. Yeah. Well, there aren't any more questions or comments, and I guess we'll wrap it up for today. Thank you two again for joining us and sharing everything. Thank everybody for joining us and watching. And then, oh yeah, Rose confirmed Penticton. Yeah. Mary Trifonopoulos says, thank you so much. I haven't seen Mary's name in quite a while. Won't have to, yeah, okay. Yeah, okay, great, thanks. I hope everyone has a wonderful day and stays warm, and see you soon.
Thanks so much, everyone.
Bye.
Okay. Bye-bye.
Bye.